I'll be talking on detachment detachment in cataract surgery, which is not very uncommon. Uh, the reasons why you should be knowing about detachment detachment is important. Then only we can prevent and manage it. The incidence of DM detachment is about 0.5 to 2.5%, and it is more common after wound construction by keratomes rather than femtolaser. So we divide the risk factors of DM detachment to patient related factors and surgical related factors. In the patient related factors, loose DM is present in people who have a mutation of TGF beta induced gene dysfunction of keratoepithelial protein, which leads to the weak adhesion of DM to the posterior stroma. The other causes are mature cataract, hard cataracts with pseudoexfoliation, Fuchs endothelial dystrophy, and of course old age. Amongst the surgical factors, uniplanar and anteriorly placed incisions are most important. Blunt keratome causing irregular internal wound, careless instrument handling, inserting instruments with collapsed anterior chamber, inserting phaco tip or hydrocannula with the irrigation on, forming anterior chamber at the end of the surgery. That is another way where it can go wrong, and longer phaco time is where the DM detachment has been found to be more. These are some videos which are just highlighting how the DM detachment can occur. This is a blunt instrument. You can see the surgeon is trying to push, and that is where he can lead to a DM detachment. Through a small side put, if you are trying to put a long chopper, that's where again the stripping of the DM can occur. Sometimes a small retained nucleus fragment, if you are trying to take it out, that is where hydrating the wounds is the place where it can happen, and putting a instrument through a small port, that's again where it can go wrong. So what are the signs and symptoms? Intraoperatively, you will see a fluid wave which passes between the descemet membrane and the posterior stroma, and a localized or a detached folded DM can be sometimes visible also. If you look at this video, you see that the surgeon was trying to get a small nucleus fragment, and as the tip is coming towards the wound, the hydration port, the fluid passing through the port causes the DM to detach. In this video, you can see how the surgeon is actually putting solutions at just at the wound, not inside the anterior chamber. So that is where, see here, the wound is not the place where you should put in the fluid. It should be inside the anterior chamber. Now you can see when he is removing the fluid, the DM is already detached. This is a video I have taken from cataractcoach.com, where you can very clearly see the wound. Exactly at the wound there is a irrigation port, and that is where the DM is detaching. Post-operatively, if the patient does not recover vision in about a week's time and the cornea remains hazy, especially the haziness is near the wound, then you must do a imaging to find out if the cornea is damaged due to endothelial damage, or is it because of a localized DM detachment. And if you find the DM to be detached, then you have to look for the free end to see whether it is rolled up or it is flat. If it is a rolled up, then it has to undergo a surgical intervention. If it is a flat detachment, then of course it can be conservatively managed. There are various classifications given by McCool, Samuel, health classification, which takes into account height, extent, length, and position of the detached descemet membrane. But what is probably important is the classification by Sharma, which gives us how do we go about a superior detachment with a planar position of the descemet membrane. You can just do a intracameral air and get away with it. But if it is a rolled edges, or if it is an inferior detachment, then in that case you have to go for a gas which is of which will stay in the anterior chamber for longer period. So management, it is mostly conservative because most of the detachments are small and limited to the wound area. So you can just observe, or you can go give hypertonic saline rock inhibitors. That would help. If the detachment is bigger and it does not resolve over a period of a week or 2 weeks, then the wound must be closed. Air or a non-expansile SF6 gas, which is about 15 to 20%, should be injected, and avoid face down position. The patient must be told to remain supine, not prone. Give aqueous suppressants. Over a period of time, the DM attaches and the cornea clears. So to conclude, it is best to prevent if the detachment is small and is detected on the table. Suture the wound and give air. If it is large and detected on the table, give non-expansile SF6, which gets absorbed in 7 to 10 days. If it is not detected on the table and you suspect the cornea is not clearing up by 1 week of time, confirm by intersegment OCT, treat as per the stage. Indication of laminar keratoplasty is usually if it doesn't recover in 3 to 4 months, or if the corneal thickness is progressing in spite of medical management. Thank you. Thank you for the patient hearing.